Welcome to the Gender Affirming Care Lunch and Learn series. Today, our topic is gender affirming care and HIV treatment. Before we move into the speakers, I'd like to start us off well with a land acknowledgement and recognition of today being the Trans Day of Awareness and Remembrance. I join you today from traditional Indigenous lands. As a settler, I recognize that gender affirming and HIV-related care continues to be shaped by colonial systems that create barriers for Indigenous peoples. This acknowledgement is a reminder to center dignity, safety, and reconciliation in how we support communities. As well, today is Trans Day of Remembrance. We honor the lives lost to violence and the AIDS epidemic, and celebrate the resilience and brilliance of transgender, diverse, and two-spirited communities living with and affected by HIV. And now, introduction of the speakers. First, we have Dr. Jason Latsky, who is a family physician specializing in LGBTQIA plus primary care, sexual health, HIV care, and gender-affirming hormone therapy, providing culturally competent and inclusive healthcare. Dr. Latsky offers services such as PrEP, DoxyPEP, STI treatment, and routine primary care. And next we will have speaking Aspen Groom, who is a social worker and activist dedicated to advancing 2S LGBTQ plus health and well-being, with experience as a sexual health educator, support worker, and system navigator. Aspen is completing a Master of Social Work at Laurentian University, where their research explores adaptive mental health interventions for marginalized populations. And now I'll turn it over to Jason.
Thank you very much, Thomas, for that introduction. Let me quickly share my slides here. If you can just give me the go-ahead that are we seeing the screen?
Yes.
Yes.
Okay, wonderful. Thank you guys so much. So, there we go. Okay, it is working. Cool. So thank you very much for the introduction. I won't spend too much time on who I am, but I do think knowing who's talking to you is a little important. So I'm from Montreal. Did my undergraduate at McGill in anatomy. Then I studied in the sunny Caribbean island of St. George's and got my medical degree. I obviously have always had a love for LGBTQ medicine. It took me to the Fenway Institute in Boston, which is one of the premium LGBTQ clinics and research institutions in America. And then I got a little homesick. So after lecturing around America last year, I decided I'm coming home to Toronto. So that's a little bit about me. And this is really aggressive of me to get talking to HIV trans care, the intersectionality, in under 20 minutes. So I am going to try my best. I'm really excited to field any questions and help understand in any way we can. I think most people on this call will be familiar with this type of picture. I always like to start off with this picture, which is sort of the different layers of society and what causes stressors and barriers to care and all that. And I do think that barriers are very important in HIV medicine and trans medicine. This is the first time I've actually seen this part of that photo. So I think it really, really speaks volumes into the intersectionality of the barriers of care and stigma that 2S LGBTQIA plus individuals face when seeking care. So why do we have increased risk of suicidality, substance use, eating disorders, psychological distress, depression, anxiety, PTSD, and most importantly for us, some sex work and increased STI and HIV prevalence? The reason is because all of these institutional, structural, interpersonal, and minority stressors that we see in our medical system cause these psychological stresses on the person and creates a vicious cycle that makes them have coping behaviors. I think that's really, really important as the number one thing us as providers, social workers, and care workers need to recognize. And I'm going to build a lot on this topic during my presentation. I wanted to frame my case around, I'm going to call this patient Effie. If any of you are familiar with the lovely Effie trinket there in the photo. So that's going to be my patient. This is my real patient who I've seen recently since August, patient FC, but I'll be referring to them as Effie. And TIC stands for Trauma Informed Care. And I just wanted to give you guys a real life example of how this approach, I believe, saved this patient's life. So a little bit about trauma-informed care. This is stuff that I bring to my practice in HIV medicine and also primary care, is the 4 Rs. So we want to realize that there's a disparity and recognize those affected. We've sort of done those things with recognizing all the institutional barriers to care that we're all familiar with. And then we need to respond with equity and empathy and resist the system and empower ourselves to learn and make change. Really briefly, I want to bring up the concept of equity. I think it's really important. A lot of people believe in equality. So equality means everybody gets the same thing. Equity means that we understand and we're empathetic, that some people require a little bit more of something in order to get the bare minimum that they need to in healthcare, for example. So as you can see in the picture, if everyone gets 1 box, that doesn't necessarily help everyone. Some people need 2 boxes, some people need 0 boxes. So I operate on the equity principle, and I think it's really, really, really important for us to recognize how many boxes our patients need and that we're there for them with those boxes. What do I do with these boxes? This is my favorite slide. This is called the trauma-informed lens, and this is my go-to for trauma-informed care. So trauma-informed care is recognizing the behaviors on the left that those of us who don't use our trauma-informed lens will see. Things like a patient being manipulative, scared, lazy, forgetful, attention-seeking, withdrawn, uninterested. Those are all descriptors that I've seen in medical literature. And then that's without the trauma lens. When we put the trauma lens on, we realize, oh, the patient's not manipulative. They're resourceful and acting from a place of a survival instinct and seeking control after having been negatively impacted by our system for many years. And that's why they appear manipulative. So it's really, really informed. Now, it's important to know when to use our glasses. We shouldn't use them all the time. There are some people, unfortunately, that are bad actors. But my goal with this slide is it's supposed to give us a mindfulness moment to take a step back and realize, why is my patient behaving the way they're behaving? What can I do to recognize these behaviors and empathize with those behaviors? And just be someone that wants to listen to them and take them out of that fight or flight defense mode, because they're in there, let me tell you. So briefly, how did I deal with Effie? I use this history tool that I developed, which is just a brief template that I use. I won't go into it in excruciating detail because I don't want to waste time, but it involves getting a brief history of their coming out and social transition. So just getting a feel of their how long they've been living their truth, finding out about their support system. Do they have friends? Do they have family? Are they running from people? Like, this gives me good social information. Obviously, screening for mental illness. Therapy is always a good thing to encourage, but not required. And then I always ask them for their goals and what they would like from me. So what does that mean? I frequently get, again, this is the whole, like, they're coming in sort of upset and they're like, well, you told me to do this and blah, blah, blah. So this is really important with HIV care, with any care. So I'm always very calm, redirecting, and always educating my patients. Like, I'm always explaining everything to them. Why do I do things? And I ask their input on it. Okay. It's really important that when you're taking your history that you don't over medicalize somebody. So, just use really casual language. Don't try to use DSM-5 language, like, when did you start to feel gender incongruent? Use things like, when did you first feel different? Or like, your body did not match up with your gender. Tell me a little more. And then if you do have to medicalize them, just explain why you're doing it. We can skip that slide. and get into the meat and potatoes of what we wanted to talk about today. So what is the intersectionality between gender affirming care and HIV testing? HIV in general. I think HIV care, one of the most important things is that recognition and getting the patient to come in. So let me take a moment to tell you actually about Effie and what happened. So Effie came into my practice in August, and she was a very withdrawn, shy individual, very did not want to divulge a lot of information, but was very honest. And she agreed. At first, I wanted to do general blood work. I always screen for HIV. And she was very hesitant. Why do you want to do this? Very, very inquisitive, very shy. I can tell very, very damaged by other medical providers. So I explained to her and I said, look, honey, I just want to look out for what's best for you. I do this for everybody. I'd love to, check on your estradiol. I'd like to check your sexual health. I want to check all your organs. I think this is really important. And I could tell after I explained all that to her, she took a big breath. She had a sigh of relief and she did her tests. Unfortunately, a few days later, after her testing came back, she did, in fact, test positive for HIV. This was a little shocking to the patient, but because we had already established this very relaxing, it was only one visit that I had with this patient. So at this point, I thought that, oh my God, what a tenuous relationship. She's going to hate me. She's going to leave me. She's not going to want to come back. She came in, we hugged it out. We had some tears. We talked about the next steps. And she was so thankful that I was just explaining to her everything in a very calm and not over medicalized way. And I was always asking for her how she felt and what she wanted to know. Was this too much? So summary of the story is I used my trauma-informed care from the get-go to create a welcoming environment for my patient. And this enabled her to proceed with HIV testing and to proceed with HIV treatment. It's now November. She was immediately put on the right medicine. She's immediately undetectable. In fact, she disclosed to me on the second encounter that she was sexually abused by an individual and felt so comfortable with me to tell me this important information that we were able to open a police file and get caseworkers involved and really help her get her out of a dangerous situation and keep her safe. So I think it's a really good case to illustrate how trauma-informed care and just being there for your patient is more important than the medicine itself. But I should talk a little bit about the medicine. So what I do want to point out is, as you can see here, HIV is only detectable as early as 11 days post-infection. So that little green arrow showing the HIV RNA test, we don't even really do that in Canada. So our 4th generation HIV antibody test, that one really only shows up at around day 15. If you're doing it through public health. So that one, it's really important to understand this because a lot of people will come into your office and say, for example, unfortunately, this person, I had an incident yesterday. HIV testing is not really going to be positive. However, it's really important to get that baseline. So I always encourage you to get a baseline test and then repeat your test at least 2 weeks after, if not a little bit longer, just to make sure that we're not in what's called this window period while the HIV virus is cooking. So that's the point of this slide. Really, really brief. I'm really not going to get into mechanism of action. I just want to talk about how drugs generally work in HIV medicine. So we have a variety of drugs that stop the virus from integrating into the complex, which is the integrase inhibitor. And then we have the reverse transcriptase inhibitors, and that stops the virus from being able to make copies of itself. So you might hear words like INSTI or NRTI, all of that. So all it is we want to use HAART or HAART, highly active antiretroviral therapy, to stop HIV. Most HAART regimens include 2 reverse transcriptase inhibitors and an integrase inhibitor. I won't go any more complicated than that. I will give you some recommendations on how to get someone started shortly. Here we go. So if someone were to come into your clinic and be tested positive for HIV, number one, you want to make sure that this is a true positive. Public health does do some double checking on their end. So it's really, really important to get the result, match the patient, make sure you have the right result. Once you're sure that this patient is in fact HIV positive, it's really important to provide support for that patient and make sure that they're ready to hear the information, because our goal as medical practitioners is to start someone on highly active antiretroviral therapy as quickly as possible with the least amount of barriers and the most amount of compliance. And the way that I found to do that most effectively, again, is to approach everyone with a trauma-informed care and open arms. So how do we do it? The best medicine that we have available to us is Biktarvy. Biktarvy is a medicine made by Gilead. It is a wonderful combination of two integrase inhibitors, two RTIs, an integrase inhibitor. So it's bictegravir, tenofovir, alafenamide, and FTC or emtricitabine. So essentially, it's like PrEP plus bictegravir in one pill. It's very, very nice, very few side effects, very limited chance for resistance or any issues. So if you can remember one thing, start a patient on Biktarvy. It is on the Ontario Drug Database. So if someone's less than 25 or over 65, it will be covered. Additionally, it's a medicine that can be added to the ODB through ODSP, disability, or special circumstances. So working with your case managers and really having all those resources to get someone on the medicine as quick as possible is your best bet. For whatever reason, if it's not covered, it is quite a costly medication, costing around $1,800 a month. So there is an alternative regimen. So the second regimen that is a little cheaper and more affordable, still quite expensive, would be combining Tivicay or dolutegravir, which is listed here on the right-hand side with this little yellow pill, with normal PrEP. So if your patient, say, was on PrEP, didn't take their pills properly, got it, and they have a bunch of PrEP at home, you can use PrEP and then add the dolutegravir on, and that becomes HIV therapy. PrEP alone is not enough for HIV medicine. We need to have at least 3 medications in there. So PrEP is 2, Biktarvy has all 3 in them, and then the dolutegravir is the 3rd medicine that we can use to start. And then, of course, getting that person connected with all the right resources, all the right community managers. I don't want to steal the next speaker's topic. I think is going to be paramount in their care. And then getting them to someone who can help manage their meds is super, super important. So I think I flew through that a little quickly. We are 15 minutes in, but I just really wanted to reiterate 2 or 3 really key points. So I'm going to review those key points. Number 1 is to always approach patients from an aspect of equity and recognizing that some of them may have had some traumatic experiences. If you recognize that in your patient, being able to use your trauma-informed lens to recognize behaviors in patients and approach them with a little bit more empathy so that you can build that rapport. And then that will enable you to be a really good ally for them in providing care should they become positive with HIV or anything else that you fall with. And you guys will make a great therapeutic relationship and have a wonderful experience together. And Effie has given me multiple hugs since I started treating her. She's very happy. She's in a safe place. And I am so happy that I got to share her story and a little tidbit of my information with you guys today. Thank you so much for your attention.
So hi folks, my name's Aspen, as was said at the beginning. Thank you so much for being here. I saw that there were so many folks who are in this, and it's lovely that people are interested in talking about gender affirming care and how we navigate things. So we'll take it from there. So my name's Aspen. I am a queer and trans person. I have also worked as a healthcare navigator. I'm also a social worker. That's kind of how I bring this to the conversation of like working as a health navigator within the system, but not necessarily a health practitioner, like a healthcare, like doctor, nurse practitioner, nurse, etc. To provide some context of where I'm speaking from, I have worked primarily in Sudbury. So I live in Sudbury, Ontario. That's where I work. And I think it's really important to know the nuances of how gender affirming care can look outside of major cities. So recognizing that even though Sudbury is like the healthcare hub for Northeastern Ontario, there's also a lot of nuances that come with that make it different from living in like Ottawa or Toronto or any of the cities along the 401 corridor. So kind of holding that in space at the same time as we talk about this. Just because we don't have access to certain things or the way it looks here is a little bit different, and that's okay. It's just, it will play into the way I talk about it. So I'm going to talk about a couple of key things. Um, but I was given this beautiful template of how to talk about this experience, and I am so grateful for the folks at OHTN. So what exactly was I doing? So I worked as a sexual health educator and advocate through the HIV network. And one of the programs that I worked with was the Gender Affirming program at Raise Access Network. I should note that I no longer work there because I went back to do my master's, but just holding some space that I worked there up until September. And so this information is based on those experiences. And when I was working in HIV care, a lot of my responsibilities involved not so much looking at how do we provide care to people who have tested positive for HIV, but holding space for how do we do that advocacy for folks who are at a higher risk, and knowing that trans people, especially the trans people we were working with, are typically at a higher risk of HIV because they're folks who are not able to navigate the healthcare system in the typical ways of access. And when I talk about typical ways of access for gender affirming care, we're talking through a family physician or a nurse practitioner's clinic where they're roster, as opposed to coming to our clinic, which was for anybody who needed gender affirming care and could complete the self-referral form or call myself and we could complete it together. So keeping that as few barriers as we can. And so what did I do? Well, there were three main things. I would act as a translator. So when we think about that trauma-informed care lens, some folks are able to do this within their practice, but knowing that some medical professionals it doesn't happen. So that would involve, yes, dealing with medicalized language, but also providing space and time for folks to understand diagnosis or what risk might mean or what medications might mean. Not so much from a medical lens, but from a like informed practice where people can take time to process and ask questions and go from there. A lot of my job with this was giving people the information that they probably received from a healthcare provider again, but then saying like, how do we feel about this? Where do we go through this, and how do we go through this in a good way where people feel like heard and valued? My next pieces were like connections. A lot of my job was knowing the right places for people to go, which is a lot more overwhelming when you live in a large city. But knowing that I was the only person who worked in the HIV sector who was working with 2S LGBTQ folks in our community, there aren't that many across the North, period. And so really having an idea of who do I refer somebody to if they need like Trillium for drug coverage, if they need, can we connect them to someone who can help them, support them with like getting their legal documents changed? What does that look like? What is that process like? And being able to walk it through with them, even if I'm not necessarily the person to do that work. And then also knowing like the challenging pieces that are unique to everyone's local communities of how do you navigate things like housing, or who do they go to for housing if they're not housed, or they're living like they're what we call like truly they are not housed, but they're like living with their friends on their couch, or living like these pieces that we often see, especially in queer and trans community, and understanding how those networks work and what might come with those networks. And the last thing that I talk about is I did a lot of advocacy, and sometimes I say that I like was not well liked in community for doing this advocacy, because it often involved pushing back against folks who have a lot more power and privilege within the health system. And so I'll give two examples of that are quite simple. One of them is that I, I our internal EMR system required certain data to put somebody into the system. An example of that would be like an address. And so we quickly realized that our self-referral forms, if people didn't have a fixed address, they would get very overwhelmed and sometimes not submit their paperwork. But I would like run into them later in community doing work and find out that that was a barrier. So that was simply removed. And then we started dealing with it once they were in our clinic, so that the idea of like, I don't have a fixed address, I can't get gender affirming care wasn't the reason people didn't get gender affirming care. Or sexual health care, HIV care, whatever they needed. Another example is that we would often push back. So it's very common for a community of like our small community clinic to get referrals from family physicians who could be practicing gender affirming care or like co-navigating HIV, sexual health care with their clients, and perhaps another like an infectious disease specialist, etc. And knowing that sometimes we would push back and say, can you do this work if we connect you to other providers who are helping do like that peer education component, which we did see in some cases, but was definitely a harder one. So when I think of accessing and engaging approaches to trans clients living with HIV, what can frontline workers do in their own jobs, intakes, follow-ups? I kind of established this into 5 points. And really it's quite like they're really simple of like meet patients where they are, don't make assumptions about their gender or their feelings or what they're looking for on intake. And don't make assumptions of if you think that they might be doing something that, you know, from a medical lens is not agreed to, that we don't love. So an example of one that we've seen and that I've seen in community as somebody who also works in community is that it's not uncommon for folks to find alternative ways of starting hormones. And knowing that, you know, there's genuine medical safety concerns that we need to address and be aware of, but also if somebody's already doing that, we just need to be aware of how we respond to that as people who are working within the medical system. And then other things of like when we take non-assuming approaches, making sure that we're acknowledging our position when we meet them. So be like often I'm like, hi, I'm Aspen, I use they them pronouns. Can I ask you what pronouns you use and what name you would like me to use for you? So making sure that those simple steps are covered. The next one is coverage and cost, which is just a navigation that, as we heard, Biktarvy is incredibly expensive. And though there are ways of navigating that with clients, and certainly our clinic was connected to some compassionate funding where we could start folks on medication before we necessarily had like the coverage pieces figured out for HIV care. Knowing that if we have the internal process of how we can do that and the people who know how to do it well are already connected to us, that certainly would make things a lot less like stressful for folks. So saying like, hey, we have a plan and we can get you on this course ahead of time. And then the third one, which I think is actually the most important piece, is being aware of where you're sending folks for gender affirming care, the organizations, all of the pieces that come for that is really critical. I can say that an example that I use there is that if you're referring somebody to Montreal for gender affirming surgeries, there are some caveats to that of like how they do aftercare for patients and what that looks like. And so it's really important if you know those things to be able to let patients know ahead of time or to support them in navigating. And as a healthcare worker, sometimes like in that situation, sometimes my job with folks who would go to Montreal, GRS would be like, we need to make sure that you have a doctor who's going to take on your aftercare in your local area. Recognizing the local area in Northern Ontario could be like Timmins. And like, we need to make sure that you don't have to travel 3 hours after having a surgery after X-Wins. And then the last two are really like medication knowledge. So like, do you know the meds? Can you talk about them in general terms, or can you refer them to a physician who knows better? And finally, like retention of like making sure that people feel welcome and that's what gets them coming back. And so it's really lovely, the conversation before this and the presentation that talks about gender or trauma-informed care. Because what we know is if we explain things to people, if we listen to them and we don't judge them, and if we make them feel seen, they're really likely to return. And so we had this really, really wonderful medical oh my gosh, my brain is our administrator, our medical administrator, who made an effort of knowing who people were, making them feel welcome in the space, and always knowing that like sometimes our clients, because we're often working with folks who are not connected to healthcare in other ways. So in this particular instance, if they were late, it was still like we're happy that you made it, as opposed to like, well, we might not be able to see you, which is very common in other spaces. Going to the next slide. Addressing for social needs and safety, taking note of this, and this is where like we all know, or many of us who work in healthcare know that wraparound care is like the dream that we wish we could have and a reality that we don't always see. But when working as a healthcare navigator, that really my goal is to be able to say, we might not have that service, but where can I send you that I know is maybe safe or safer, or we can prepare for you to deal with a situation as somebody who might be gender diverse, who might be dealing with HIV or sexual health challenges, can can be prepared of what about it might not be safe. So are you going to get misgendered and that's going to be the struggle, or are you going to have to deal with like ID that doesn't match, or perhaps missing ID, etc. So knowing those sorts of things in advance. And these 5 topics are just the ones that we saw most frequently. So thinking of like housing and income or employment, or substance use, harm reduction. So making sure that folks have the things they need to make the decisions as safely as they can. And that hopefully they have safe places to be, or that we can kind of like get them on a path of having safe places to be. And then just the pieces of like, are there mental health providers locally? Especially when I'm thinking of like working with folks who are lower, so for, like have lower incomes or maybe not a lot of income at all. Are there places that do sliding scale that can support other places that are covered by like uninsured health benefits, etc. Just being mindful and knowledgeable of how those services look locally, to be able to connect folks in a meaningful way. And then the other one, when we talk about like legal and ID clinics, also knowing that a lot of those things don't have to be overwhelming. And so for my work, it was sometimes saying like, how can I do this? Or is there like some folks have caseworkers who can actually do these ID or some of the legal paperwork with them or for them and sign off on it. And that there's more people are able to do more than they necessarily think they are. And sometimes it's like that coaching and that advocacy piece of saying, actually, I think you can do this. How can we make it work? Which is a lot of asking for stuff that predominantly overworked individuals sometimes are resistant to, but knowing that we can really, really impact the folks who are trying to access healthcare in a positive way. And the last one that I just put in here is like safety and other urgent concerns. This is a challenging and just a catch-all, but knowing that we've had folks who, have all kinds of things going on, like maybe they're dealing with incarceration, et cetera, that needs to be considered. And my second to last slide is just this comment of like, so much of health navigation is about building connections in community. And so knowing that like some ASOs can work together, and know that, you might have somebody who you've been supporting and lives in Toronto and has moved. And so how can we coordinate that care? But also knowing that some of that within local community is just like, getting to know people and getting to know who cares about these things and who is safe and who will be a good partner. And I always wish that this was like a valued and thought out piece when we do our work, because it does take so much effort to build these connections and be able to do that support in a good way, especially knowing like who is going to be safe for you. And finally, just the last piece here, when I think about our final takeaways of frontline practice, and these are my like candid thoughts, are just that like it's really important that we're aware of who we're connected to. We can't emphasize that enough, and know who's safe, and which places are going to be affirming, because that is going to be a huge component of if someone goes back. I can say that we've had experiences where like maybe someone who's an infectious disease specialist is actually really unsafe for their client. And so we have to find alternatives, and that can be hard and challenging and nuanced. The next one is saying that like advocacy work doesn't always mean that we're liked, especially if you're asking for somebody to do something that they really don't want to, or some learning that they really don't have time for or capacity for. And then the last two are like reassurance from trans and gender diverse folks for folks who are like trans and gender diverse, especially navigating HIV care, is really valuable. Like that lived experience makes a big difference for people to see someone like them in their spaces. And so I can't emphasize that enough. Like when we take up those spaces and support our own community, though there's a lot of challenges with that, it's really valuable. And finally, the last one is just this piece of like, it'd be nice if sometimes this work were more valued, because it's certainly like a lot of labor to put on people who are definitely and usually advocating for the community. So those are my short points. Yeah, and I think that from there, I assume we'll move to questions.
Perfect. Thank you. Thank you, Aspen, and thank you, Jason. So much information in such a short period. My mind is just swirling around. I have a couple of questions that were texted to me during the presentation that I'd like to ask, and then we'll open it up to others. Other than trauma-informed approach, is there any difference in medical treatment between trans and cisgendered people thinking about drug interactions?
That's a great question. Actually, I was meant to. Can you guys hear me? Yes.
Yes.
Okay, good. I was meant to put in a slide. I'll be very honest, there's probably about 25 different drugs that you can use for HIV. Only one of them has significant interaction with estradiol, and it's only, I shouldn't even say significant interaction. I should just say that it changes the metabolism of how estradiol is used, or estradiol in itself. So I think the short answer to the question is no. Obviously, someone with knowledge is necessary. None of these interactions are extremely hazardous, but it just warrants additional monitoring. So what I would recommend is if you have a trans person, specifically a trans woman who is on estradiol therapy on HIV, they may need to do more frequent monitoring than they're used to. If they've been on the estradiol for 5 years and they were getting yearly, they might have to go back to like the 3 months just to make sure that the medicine is not causing the estradiol to act funny. However, there's no evidence to my knowledge about dangerous things like venous thromboembolism increase, or any sort of like significant medical risk when using these. And I certainly don't want that to be a barrier to, I have Biktarvy in my clinic because we have great, crazy people that donated to us because they're amazing. And I want to give it to this person, but she's a trans woman. I don't want to give it to her. That is not okay. Start people on highly active antiretroviral therapy, get them connected. Um, yes, I wouldn't worry too much about the interactions per se, medically speaking.
Great. And a follow-up to that, do you think, generally speaking, pharmacists have resources to check drug-to-drug interactions?
So I'm going to hold my tongue on that one only because I'm too new to Canada. I have American resources. There's actually a very great resource by the University of Liverpool that is used by my Academy of HIV Medicine. It's called the Liverpool HIV Interaction Tracker. So it literally is just you type in like Biktarvy estradiol, and like up to date it'll just say like major interaction or not major interaction. So theoretically that is a resource, a Health Canada approved resource. I am not I wish I had an answer to that. That is a little research piece for myself. And then I do know that my pharmacist on staff does have his own little NACLCOM database thing that he uses. But yeah, those are all, I hope that answered the question. I'm sorry if I don't have a better answer than that.
And is that the HIV-druginteractions.org website? I don't know if that one's still active. That was
Yes, that is it, and it is active. That's correct, and I use it frequently.
wonderful. Thank you. I'll ask Tanya or Diana to put that link in the chat. Another question is there, and this is towards Aspen, I think, but I think it would be great if both of you could answer. Is there a directory that you use to know positive gender affirming providers?
I don't know if there are in other communities. I can say that locally there isn't, and I can also say that it's we've had clients in other communities who have been told that a place is affirming, and then they get there, and then it's like a bad time. So it's a very there isn't, and it's really hard to maintain a sort of directory because it is highly like it's interaction specific, right? Like if I go in and I have a great interaction with Dr. Latsky, and then I go in and I deal with a different physician, I might have a completely different experience. And that is one of the biggest challenges with healthcare when
Has
it
happened.
yeah, it has happened. And so when I the way it's like a really like challenging conversation because a lot of my work is taking what people say and then following up with providers and making sure that who is going to get there, how do we get there in a good way. And it's a lot of additional labor because the reality is that it is not consistent, and that there are a lot of places that have little rainbow things that say like we're safe here, and then we have clients come in and they're like, this happened to me there and I don't want to go back to my provider. And so it's Yeah, the answer is awful. It's like we're doing our best and we really try, and there are really good people out there, but it's certainly not consistent across most of the providers in our area.
So my best bet for this, and I ask this all the time, my practice is now almost 1,900 people. I would say about 40% of them are 2S LGBTQIA identified individuals. How did they find me? Where am I advertising myself? This kind of thing. Reddit. Apparently I'm on Reddit. And there's a Trans Toronto Reddit. So that's one, and that's not official though. But I did see two people bring it up in the Q&A. Yes, Rainbow Health is the only resource I know of that does anything close to what we're talking about, Aspen. So it's like I agree. Even in America, there is actually a grassroots NPO doing exactly this. And it's fantastic. And if we ever wanted to like partner with them and do it in Canada, I think that'd be super fun. But to my knowledge, I don't know of any sort of national database of exactly what the question was meant to address. Is it okay if I just bring up like two quick questions that were mentioned in the Q&A before
Sure.
we continue? One of them was about seeking care if you don't have primary care. Number one, I accept walk-ins. So anyone has care. If I can't take you on permanently, then I'm sorry. But if you feel like you cannot access care, you are always welcome into my office. I feel Diana, producers, can share my address with people in the chat. I'm always happy to help out. And I did want to point out three organizations: Planned Parenthood, HQ, and Safe for Six. Those three are relatively positive experiences with people without primary care that can provide episodic walk-in urgent sexual health. There was a question that came up with that on the Q&A, so I wanted to point out those organizations as safe and being okay to use. And then I think, okay, someone's asking. Okay, someone that was the ones I wanted to focus on for everyone in the public. I'll answer some Q&As more privately.
I would also expand on that if you're in Northeast, for gender affirming care, like there are a handful of ASOs, but particularly like Raise Access Network in Sudbury does walk-ins. You can, if you go to the desk and ask for what you need, they should connect you to which services are available. And then also for gender affirming care, like we have a really wonderful like children's and youth program, which shouldn't, but does include some of our clients who are, at the older ages where there's like a sexual health HIV interaction as well. And so there are programs, and that one is across the north. So they would accept anyone from northeastern Ontario. So there are some stuff in our area, but obviously we don't have 5 in the city.
Thank you. I'll just also put a plug in for Casey House. In the coming months, we'll be opening up a new primary care program, and we'll be accepting new clients to that or new people to that. And also for anyone that doesn't have status in Canada, there's the Blue Door Clinic that's housed at Casey House, but is run by a number of organizations. Another question is, what are the most important things healthcare and social service providers can do together to create a seamless gender affirming experience for people accessing HIV care?
I'm sorry, I got cut out for a second. Can you repeat that?
Sure. What are the most important things healthcare and social service providers can do together to create a seamless gender affirming experience for people accessing HIV care?
Someone's dreaming. So the word seamless is where I'm having the dream come from. I think things like what you're both doing, Aspen and Thomas, of like having your organizations including primary care in them. The light reality is a family doctor is an independent contractor. So it's like if it's really easy to pick up a primary care person in your clinic, and if you can create, because if I talk from my experience, I joined a clinic that is very well meaning, but by no means is an inclusive space. So if it was the opposite, if it was already an inclusive space that needed a doctor, I feel like that would be more suited to creating that seamless all-encompassing care. Whereas I'm now stuck like building my resources on the exterior. And again, not because my staff are mean or anything, it's just they've been operating a certain way, cis-normative for 5 years, and there is misgendering going on, and there is issues that I bring up with them, and they're making every effort to change, and we go through training, but we sort of we went through the gate cis-normative before I joined. So it's like we're fighting an uphill battle at my clinic. I want to be fully transparent on that. But everyone is doing their best effort, and we do provide pretty good care here. But I'm sorry, I don't want to talk too much. I want to let Aspen speak. But to solve that, I would say we either need to create very, very well-known digital resources for seamless coordination, or like I said, one-stop shop that you guys are doing, and I love that.
Yeah, to build on that, I think it's exactly that. It's either it has to be available internally and people need to be well informed, and that well informed piece is very real because I can think of like the folks who I've worked with who have been HIV like service workers who are really like taking on cases for folks who are living with or who are newly diagnosed, and those folks also like need to be really in the know of what's offered internally and also what's offered in community because one of our workers, this is an example, one of our workers, absolutely wonderful, knows the way that things works, and has trans folks who are living with HIV on their caseload and is really, really great at getting them like through the course. And like the way that those people feel cared for is by having somebody who's like, actually, I know where we're going, right? Like I know where we're going, and you just have to tell me when we want to go there. And that can be really, really affirming and really, really foster that sense of safety and care. But also knowing that that doesn't happen all the time, and it's like, how do we get those streamlining in place and people informed about them and aware of them from the get-go? Because I can say like there are a lot of folks, especially with like the high, like there's a lot of people in our hospital and it's like really unclear who you're going to get. And so some folks are great at, they might have a patient in like the inpatient psych unit, and we'll get a referral from them for care, or we would get a referral from them for care because they know the process of getting somebody to that. But others just, it's completely lost. And so it's really that like, can we do it in one location, or can we get people where they ought to be sending folks?
And there was a question on the Q&A that they wanted you to answer, and I'm going to put you on the spot and said we would answer it live, and I'll support you if you want. Anonymous person wanted to know why trans people are more at risk of getting HIV.
Oh, that's
I know. I'm going to let you go first, and I'll go ahead.
So I say that, but it comes down to like the ways that people cope and the ways that people need for care. And one of my colleagues put it of like, we all want to feel cared for, and we all want to feel connected and loved. And so that means that like a lot of the, and when we experience discrimination where like we might not have the same access to healthcare, we might be experiencing violence in our communities, whether direct violence or like associated violence because of identity, friends, etc. People don't always have access to the ways to cope that we would consider as like healthy coping, and I'll put that in quotations. And so what we see is people engage in behaviors that we might not always be great, like certain substance use, which also offers like a feeling of like okayness. We'll see that people engage in like sex. It's also because of some of those barriers to employment, to like well-paid employment. It's not uncommon to see folks engage in like sex work for survival. And so all of those factors that like often are seen as these really stigmatized things of why people engage in like quote unquote risky behavior affect queer and trans people, and particularly trans women. And so even locally where like I live in a smaller community, we still have lots of sex workers. The proportion of those sex workers who are trans women is higher than you would expect based on the number of trans women who are living in community. And so those folks are more likely to be exposed to HIV because of just like those behavioral fallouts. And so I try really hard to not be stigmatizing around that and just be like, this is a product of the system we live in. And so we just have to support people if they're behaving in a way that might actually expose them to HIV. Is that a fair?
I think you hit it on the head, because I got two lovely sex workers joined my practice back in July. And I guess they didn't know what to expect. They're both trans. Neither of them have HIV. However, they're both sex workers and at risk. So they were like, defensive, blah, blah, blah. We'll save you the whole story. But we had a nice casual intake. I spoke to them, and then I offered my routine STI screening, and they were like, what? You're a family doctor that like knows what STIs are? And I'm like, yes. Would you like to be screened for STIs? And they're like, absolutely. And so just like you said, it's the access to care and that stigmatization that I feel in the medical professional that I was like shocked when these people were shocked that I was not shocked that they were sex workers and that, oh well, I wasn't judgy, and I was like, okay, cool. How many swabs do you want? You want to take some home for candy? Like, like if you just have that fun building attitude and you buddy up with your patients, you create that, that space. And my patients have remained very healthy and, they feel very engaged in the healthcare and they don't feel shy coming to my clinic and saying it's swab time, but I recognize I'm a unicorn, and that's my biggest advocacy is like trying to get into like education and teaching the next generation of physicians that it's okay to be a sex worker and it's okay to talk about sex. And I feel like that is unfortunately why the trans community is just more prevalent with the HIV, because it does come down to that vicious thing I showed at first, which was that they can't access care and they're stigmatized. And so then they do all the things that you said, Aspen, and they are either through force of requirement, financially, or for that feeling of belongingness that we all crave for as humans. So I think that that's a really, really, really good take on it.
I'll also add that some of our providers have been, we've worked with and had conversations where like our baseline is like, do you want sexual health testing? And that is huge, because if it's always on the table, it becomes less of a weird thing to ask for any of your patients, whether they're here for like HIV care or sexual health care or gender affirming care, or pick the other things that they might come to like one of the clinics for. Like if it's always there, it certainly makes it less weird and you don't feel called out or judged for offering it, which has been helpful for some clients.
Yeah.
I also wanted to point out last February we ran a session on trans health, and the doctor speaking there was affiliated with a private company called GoFreddy, and I'll put their information there. I don't know if you have any comments about that, but their services are available exclusively online if you are comfortable with that. I'm thinking more for people who aren't in downtown Toronto, where it can be a little harder to access services. But there are some people also in downtown Toronto who may not feel comfortable because of some of the experiences we've heard about, that it may be another option for people.
I love that you brought that up, Thomas. I love Freddie. I tell most of my patients a lot of my patients use Freddie. And I don't know how this magician has secured some crazy deals with pharmacies to get medications at a discount. So, as Aspen is familiar, when I get patients coming in me specifically for PrEP, because that's the unaffordable sexually active between the ages of 25 and 65 and under ODB, Freddie gets it cheaper than my pharmacy. I cannot prescribe PrEP. The only people that get PrEP are corporate people with insurance, because PrEP is $400 a month minimum, and it's like there is no cheaper alternative, maybe $297, but Freddie gets it. And so when my patients come to me, they sort of, they're like, what do you think, doctor? I'm like, hey, go Freddie. I was like, if you're getting your meds and you're happy, I'll take care of everything else. You go Freddie. I'm so glad you brought it up. I love that resource.
Great, thank you. I don't know if all the questions were answered. There's one more if one of you wants to answer that. Just a reminder, the survey, the evaluation link has been posted in the chat. We really encourage you to do that. Again, I want to thank our two wonderful presenters, Dr. Jason Latsky and Aspen Groom. Also, I didn't do this at the beginning, sorry. These sessions are presented in partnership between the OHTN Health Hive, that's Tanya Oxum and Diana Campbell, and myself with Casey House. Next week, our topic will be gender affirming care and HIV prevention. I hope you're all able to attend that. And again, these sessions have been recorded and will be posted over the coming weeks. And these slides from both of our wonderful presenters today will be posted along with that or sent out along with that after the session.
Thank you guys so much.
Thank you.
Thank you. We have 2 minutes left. Any last words before?
Come say hi. Come say hi at my clinic. I want to see each and every one of you.
I mean, my words are always like, reach out to people, and if they seem not good, try somewhere else. Like there's always, there's
Oh,
always.
sorry, real quick. Someone asked a very important question. Nobody knew it, so we didn't quite get into details as to what GoFreddy is. So GoFreddy is an online service run by doctors to provide various care, including access to PrEP, sexual health, and a variety of other health topics. It's like an online telemedicine based with their own pharmacy medication. So exactly like Thomas said, if you have a lack of access either for stigmatization reasons, comfort reasons, or convenience reasons, or also just lack of access to care, you live in a remote part of Ontario, they are a great resource for you. I hope I did them justice, Thomas. Let me know if I didn't.
I think I only know a little bit about them, so. But
I mean,
as you were talking, it reminded me of that resource.
So this person's asking if it's mainly for 2S LGBTQ. I mean, they really operate only with PrEP, DoxyPEP, and HIV care. So I don't think they discriminate against non-2S LGBTQ individuals, but their services are tailored for those specific needs, if that answers the question.
yes.
And there's more info on their website. I encourage you to go check them out. Okay. And it's time to say goodbye. It's 1:00. Thank you again, both of you. I
Thank you
hope you have
all.
a wonderful day. And thank you, everyone, for taking time out of your day to attend this session. Hopefully, we'll see you next week.